Great. So we're recording now. So just keep that in mind in case we unmute the lines and you decide to speak. That this is being recorded. Again, this is our fourth NLAD network call, and the purpose of these calls again are generally to really get a chance to speak about a topic that really might improve the outcomes of our efforts around National Latino AIDS Awareness Day. We've had topics around PrEP, which we had on Monday, topics around engaging media, and one around general overview looking into data nationally as far as HIV AIDS goes, specifically around the impact of them on Latinos in the U.S. and territories. So this is our fourth call, and it's great to have you guys on it. We have about 20 people on the call with us now. We had about 40 to 50 on the call on Monday. So I understand, it's somewhat difficult to be able to be on all the calls, but hopefully through these calls we get a chance to interact with as many of our partners nationally as possible. Some general housekeeping rules or things to keep in mind. The lines are currently muted, and if you've been on the calls before, you notice sometimes when the lines are unmuted, it can get pretty difficult to hear, so we try to keep the lines on mute. If at some point you want to make a comment or pose a question over the phone line, you can do so by pressing *6. We'll also have a chance to speak and discuss openly where we unmute all the lines in a minute. And also throughout the course of the webinar, you're welcome to use the chat function on your screen, and I'll make sure to try to address any of those questions or comments you have there. So again, thanks again for joining us on our fourth call, network call. We're going to do a quick introduction and welcomes in a minute, do some general announcements in case you weren't on the call on Monday, and also go into today's topic, which is around Latinos and HIV testing, where we'll be talking about testing patterns around Latinos and HIV testing patterns, barriers to testing specific to Latinos, HIV testing technologies and window periods, and strategies and methods to effectively engage Latinos when it comes to testing. So with that said, again, for those of you that I haven't had a chance to speak with yet, my name is Tony Ochoa. I'm the Program Manager of National Latino AIDS Awareness Day here at the Latino Commission on AIDS. That's me on the screen there. So if there's at any point you have any questions around NLAD or organizing an NLAD effort locally, questions around resources or partnerships, don't hesitate to contact me. My email is there on the screen, tochoa@latinoaids.org. So what I'm going to do now is I'm going to unmute the lines right now. Again, we have about 20 people on the line. So I'm going to unmute the line. If you can, just give us your name, your city, your state, and then your organization, okay? So I'm going to unmute the lines now.
The conference has been unmuted.
So go ahead and give us your name, your city and state, and organization or group.
Raquel Calderon, Boston, Massachusetts, Office of the Assistant Secretary of Health.
Cassandra Griffin, St. Louis, Missouri, City of Public Health, Communicable Diseases.
Wonderful, welcome.
Mario Sanchez, Columbus, Ohio, Columbus Public Health.
Hey, Mario.
Mary Beth Levin, Washington, D.C., Georgetown University School of Medicine.
Welcome.
Danny Logan, Phoenix, Arizona, Phoenix Pride LGBT Community Center.
Danny.
The message is voicemail.
Okay. Marcos Sigala de California, San Isidro Health Center.
Hey, Marcos.
Javier Ortega, Santa Bárbara, California.
Hey there.
Tamash, Queens, New York, 810 Queens County.
Great, welcome.
Judy Roitman, Knox County Health Department, Knoxville, Tennessee.
Hey, Judy.
Sierra Tarry, Waycross, Georgia, Southeast Health District.
You could also introduce yourself in the chat function in case you don't want to speak over the phone.
Kit Pleco, Phoenix, Arizona, Aunt Rita's Foundation.
Welcome.
Mark Rodrigo Rodriguez, North Carolina. Rodrigo Rodriguez, North Carolina, Wake Forest School of Medicine.
Hey, Rodrigo. Okay. Well, this is good. I mean, generally it's somewhat difficult to hear, so I think the fact that it's not difficult to hear one another When we have the lines unmuted, it will make it easier for us to have discussions when we unmute the lines. So again, thank you all for joining us. I'm going to put the lines back on mute, but again, don't hesitate to raise your hand or unmute your line to make a question or use the chat box during the course of our discussion, okay? So I'm going to mute the lines back up right now.
The conference has been muted.
Some quick NLAD announcements for 2015. Just like you did before, on Monday, on the screen you'll see the posters for 2015. This year's theme is You and I Will Defeat AIDS, or in Spanish, Tú y yo vamos a derrotar al SIDA. And under each one of those figures, you see different prompts in which someone might be able to commit to actions as far as what they could do as a person, as an individual, that would help ultimately address the impact HIV/AIDS has had on the Latino community. And in general, it's a pretty diverse poster as far as what Latinos look like racially, and it's beautiful as far as it's vibrant. It's not a sad poster, which is something you want to make sure we do. You don't want to make sure it's a daunting or fear-based campaign ever. So we address things around testing, around stigma, around PrEP, around medical adherence and treatment, and of course there's plenty of other things we can dedicate as far as things that could be prompts like around condom usage, condom negotiation, intravenous drug use. So again, these are just simple, basic prompts, things to initiate conversations, but we understand we can't cover them all. So these are things I think that really mirror some of the things we're seeing around the National HIV/AIDS strategy and things around the continuum of care. So we're excited about sharing them with you. They'll be available on the NLAD website, and the website's slated to go up live on the 1st week of September, so next week. On the website, you'll also be able to enter your event information so that partners locally can either connect with you or community members can find their events locally. Media can engage you. So again, there's lots of benefits to making sure that you register on the website to kind of make sure you enter your event information and it's shared publicly so that people can know what you're doing locally, give you credit for the work that you're doing. You'll also be able to access testing kits on the website. And also campaign kits, which include the posters. The posters you can download directly from the website in case you want to type in your event information. I would love to be able to customize each and one of the posters for every partner, but it's resource and financially somewhat impossible for us to do, being that we have over 100 and something partners nationally. To be able to customize posters for every single partner is something we can't do, but we can definitely provide you with the electronic version so that you can enter your event information and your dates and the event details so that you can print it in case you want to go down that route. So again, the next call is going to be, we're on the call now, but there's another call on Monday, and that one's going to be around Latinos and the Affordable Care Act. So as you can see, we've had several discussions so far in network calls with different topics. The first one was an overview of Latinos and HIV in the U.S. independent areas. We had one around engaging media through press conferences. The one on Monday was on Latinos and PrEP. This one today is on Latinos and HIV testing. And then the one on Monday is going to be specifically around Latinos and access to care. The Affordable Care Act. And then the one on the 3rd of September is going to be around how do we make sure that we have effective NLAD events locally. So how can you make sure that you're getting the most out of your NLAD event? And that's what we're going to talk about on the call on the 3rd. So you should be able to register for the other webinars if you haven't done so already in that same email where you got the invitation for this one. There's a little link on the bottom that says register under each one of those webinar topics. So with that said, are there any questions or comments? I'm going to unmute the lines right now. So any
conference has been unmuted.
Questions or comments?
I do have a question.
Sure.
Again, is there any way that we can get notes or from the previous conference? Because I was basically got here late and I didn't see that there was some previous, and I would like to see what was the discussion about or something like that.
Definitely. So what I do, like I said, we record the webinars too. So what I'm going to do later this afternoon, I'm going to send an invitation to everyone for the next two, and in that same email, I'm also going to include the links where you can watch the webinars and also download the slide set.
Okay, thank you.
No problem.
Yeah.
Else, any other questions or comments about NLAD, about resources, anything whatsoever? No? Okay, no problem. We can get into our topic. I'm going to go ahead and mute the lines again. There's ways in which...
The conference has been muted.
I've tried to make this discussion as far as HIV testing goes and Latinos a little engaging. I included some poll questions to try to make sure that we're engaged as far as, the content goes. So let me know. Hopefully you guys find that as an entertaining process to make sure that we stay along topic. So again, Latinos and HIV testing, this is something that we think is a critical part to NLAD. NLAD has traditionally been a very HIV testing focused campaign. But it's understood that Latino HIV/AIDS awareness isn't always about testing. There's other things we need to tackle, like PrEP and prevention and treatment, and as such, right? So, but nonetheless, HIV testing is still a pretty critical part of the work that we do as a campaign and as a mobilization effort nationally. So what we're going to start off with is a quick discussion around testing patterns and barriers specific to Latinos and HIV testing, right? So the first poll question I have here on the screen is, in 2013, how many Hispanics Latinos were diagnosed with HIV in the U.S. and territories? And the options are 150, 2,345, 8,345, 10,888, 1,462,156. So which one of those do you think is the right answer? You have 5 options there. Go ahead and select your option. So how many Latinos were diagnosed with HIV in the U.S. and territories in 2013? So once you have about a good number of people enter a response, we'll click display. So go ahead and enter what you think is your best guess. So you have about 15 people answer so far. We have about 23 people on the call. We have 16 people answer. All right, so out of the 16 people on the call with us now that answered the question, we see that the majority of people answered, around 41% of the people that answered the question said 10,888, and that's the correct answer. So in 2013, there are around 10,808 cases of HIV diagnosed amongst Hispanics in the U.S., and that includes the territories too. So of the Latinos diagnosed with HIV in 2013, about 86% were male, 14% were female. Between 2008 and 2010, Latinos living with HIV increased by 8%, compared to an increase of 5% amongst whites and 7% amongst blacks. And again, that point right there isn't necessarily always a bad thing. This accounts for morbidity and mortality. So the fact that this could very well be due to the fact that we're living longer with HIV, so the number of people living with HIV is a lot higher because of medication and treatment, which is a great thing. But also, make sure to keep that in mind when we look at that number. The leading cause of HIV diagnosis amongst Latinos in the U.S. continues to be male-to-male sexual contact, which accounts for 79% of new diagnoses, and that was in 2011, right? So then I have another question for you guys. What percentage of Latinos ages 18 to 64 reported ever being tested for HIV? So how many Latinos between the ages of 18 and 64 reported ever being tested for HIV? Is it 12%, 30%, 43%, 53, or 72? What's your best guess? So what percentage of Latinos ages 18 to 64 reported ever being tested for HIV? So you have about 13 people answer so far. Just take your your best guess. About 15 people, 16. I'm sure some of you are sharing screens, so I'm sure you might be fighting over who gets the answer. So great. So here, let me display the answers now. So we had about 16 people that are on the call with us answer that question now. So the majority of people said about 30%, about half of us said 30% of people 18 to 64 Latinos reported ever being tested. The second answer was 12, and then about even split between 43 and 53. So based on findings from the Kaiser Family Foundation, it's actually not terrible. About half, 52% of Latinos ages 18 to 64 report ever having been tested for HIV. So Latinos 18 to 64 are more likely than whites in the same age group to report having been tested for HIV in the last 12 months. So 30 and 14%, right? So amongst those who are HIV positive, CDC indicates that over a third of Latinos, 36%, were tested for HIV late in their illness. And this is key. This is a very key part to the reason that we do the work and really focus around HIV testing, is that Latinos are testing late when it comes to HIV. And what does it mean when you say Latinos test late, right? That is, they receive an AIDS diagnosis within 1 year of testing positive. And that's compared to 31% of when we're talking about blacks. 32 when we're talking about whites. So again, this is a big concerning issue when it comes specifically to Latinos. The Latinos are testing late at a higher rate compared to any other race, right? So the fact that Latinos are receiving an AIDS diagnosis so closely after receiving an HIV diagnosis is pretty telling as far as the work that we have left to do and the importance around HIV testing in Latinos, which is why we're having this topic, and it's something that's very pressing for us to make sure that we tackle when it comes to talking about testing in Latinos. So another thing I want to kind of mention and look into is that beyond just testing, we want to make sure that once someone finds out they're positive, that we link them to care, that they're retaining care, meaning that they're seeing the doctor regularly, as prescribed. They're receiving a prescription for treatment, and ultimately our goal is to make sure that everyone that's positive is virally suppressed. And again, the importance of having someone become virally suppressed is because if someone's virally suppressed, the likelihood of them living longer is greater. The likelihood of transmission is reduced. So there's a key part to both a person's benefit and also general interest to make sure that someone is virally suppressed. And this is kind of where the key term of treatment as prevention came from when it comes to the work that we do in the HIV/AIDS field. And what you have on your screen here is you see that I compared Latinos to the general U.S. population, right? So we see Latinos specifically, about 80% are diagnosed, so that they know that they're positive. Around 64% are linked to care. Around 37% are retained in care. 33% are prescribed antiretroviral therapy, and about a quarter reach viral suppression. So again, there's a lot of area for growth and improvement here, and we can see Latinos tail slowly behind the general U.S. public. So again, a lot of work for us to do here. But one of the key things I want to make sure I focus here, especially when we talked about data and epi data specific to Latinos nationally, is that this isn't always the case locally. And prevalence and incidence and the rate of which an infection is growing specifically amongst Latinos really depends based on your region, on your state, and a bunch of other factors. So what I want to do here is, if you haven't had a chance to go on AIDSview, AIDSview is a great site. It's very user friendly. It's a great way for you to start looking into what is going on as far as epi data in a visual way. So I encourage you to go to the AIDSview website. The link there is on the bottom, and I want to very quickly walk you through what that looks like state by state. So I'm going to share the screen so that I can access on the browser right now, and I want to make sure I walk through some of these numbers with you on the site, so you can kind of see how it looks different across the country when it comes to HIV new diagnosis. So you should be able to see my web browser shortly. Hopefully it didn't freeze on me. Give me 1 second. Shoot. Okay, so I'm guessing that might have caused a problem here on my side. Give me a second while I try to see if I can figure it out very quickly. Alright, so hopefully you should be able to see on the screen now. So on your screen you see that I have my browser open on the AIDSview website, and you see on this side here on the left, this is specific for data from 2013, and I'm looking at rates. So this is the rate, and the reason why the rate is important is because instead of just accounting for the number of cases, meaning the number of people that are positive, that were found positive in 2013, it accounts for the size of the population too. So this is kind of giving us a rate, and it gives us a clearer picture as far as what's going on in real time, if we kind of put real time in air quotes, based on the size of the population in that specific state. So the darker the purple, the higher the rate of HIV infection or new diagnosis is amongst Latinos. So you see here I have specifically tagged and selected Latinos, and the darker the purple, the higher the state. So you see in Georgia in 2015 the rate of Latinos adults in that subgroup, there were about 45 Latinos per 100,000 people, Latinos in that state, that were found positive, right? So, which is compared to Florida, where it's 37 out of 100,000 Latinos in that state that are positive. So again, it accounts for the size of the population and the number of people in that ration that were found positive, right? So again, these are key things to look at when we're talking about testing. because it really lets us know how high of an incidence or prevalence that number looks like in our specific state and regions. And even if you look even further, in some states, because they're so large, or because the pockets of Latinos look so different, some cities and localities have higher incidence than others. So you can get very detailed depending on your locality beyond just the state level, right? So I'm going to go back to my screen now. So again, I want to make sure I give everyone a quick snapshot of what's going on with Latinos as far as testing goes and testing patterns, the fact that Latinos are testing late, how many people are testing positive, how many Latinos are testing positive. And I wanted to make sure I highlighted something. The major highlight out of this is that ultimately, across the United States and territories, the Latinos account for about 17% of the U.S. population, but we're about 23% of new HIV infections. This is key, and these two numbers let us know that Latinos are being disproportionately impacted by the epidemic. So there's plenty of other factors why this is the case, right? There's things like, lack of health insurance, language barriers between, the service provider and the monolingual Spanish-speaking Latino, the lack of familiarity with U.S. healthcare systems, stigma, all these things really influence the spread of HIV among Latinos and their access to care, right? So before I move into testing technologies, I want to make sure I give a chance to unmute the lines and hear any comments or questions. So I'm going to unmute the lines again very quickly before we move on to the next section.
The conference has been unmuted.
So does anyone have any questions or reactions based on what we just saw right now? We have a shy group today, and it's okay. You can also type in your questions or comments in the chat box.
Well, I do have a comment, and basically, well, first, I congratulate you for the work that you're doing today. One of the things that we have seen, at least here in Ohio, one of the biggest problems, and is sometimes to schedule any event or everything, is the lack of numbers. The problem that we have is that many times when we're testing Latinos, we are not counted, because it's more done by racial than for ethnic group, and for the most, it's very hard to get money for a community when we are not being counted.
And that's an obvious structural barrier that you're bringing up there, and I think that's something that's important for us to bring up and realize and acknowledge, because if that's something as simple as not accounting for, or even just monitoring that when it comes to intake process, that's key. Because ultimately, if you're not recording that, there's no real way to make sure that's being tracked. And I encourage you to kind of do a little investigation there and find out whether that's an agency protocol, if that's something you can try to do within an agency, or if that's a larger jurisdictional issue when it comes to.
It's larger, actually, because
I definitely encourage you to kind of seek out and advocate for those changes. Those are crucial changes that need to happen.
Because the problem is, I don't know if it is something in Ohio or something else, because what I told is this is a CDC procedure.
That's not true. Not true.
I don't know. That's what I was being
Definitely
told.
not CDC. If anything, CDC is pushing to make sure that we account for as many of these subgroups as possible, and Latinos and Hispanics are a major component to making sure that information is being captured. So if in your intake forms that's not being tracked, I encourage you to...
It is being tracked, but the problem is it's being tracked as a secondary part. So, for example, if somebody includes the race, it will be the first item that they will take, not the ethnicity.
And definitely, I mean, if we can dig into talk, because again, as a Hispanic Latino population, race could be anything. So you can have a Hispanic Latino that identifies racially as black, and if you look at EpiData at a national scale, it breaks it down as ethnicity and also by race. And there's a keynote that says there that Latinos can be identified across multiple races. So it doesn't mean that it's not being counted. It means that it's being segmented differently, but it's still there. Okay? Very good points. Very good points. Because all these things and comments are critical in the way that we digest information and the way we can use this information to make sure that we advocate for the work advocate for more funding, for more recognition around the work that we do, right? The key things. Javier said AgeView looks great. Thanks for sharing the link. Of course, I mean, AgeView is an amazing source. They're actually one of our partners, and It's a very basic way to graphically start looking at epi data and see how we can try to digest it to influence the work that we do. Okay? So with that said, I'm going to put the lines back on mute and go into our next section where we start looking specifically into testing technology.
The conference has been muted.
All right. So before we get started, I have a true or false or not sure question here, right? So the question is, acute infection and window periods are the same thing, right? So are acute infection and window periods the same thing? True, false, or not sure? Go ahead and give us your best guess. Acute infection and window periods are the same thing. So you have about 12 people answer so far, 13, 14. So are acute infections and window periods the same thing? Okay, so you have about 16 people answer. So the majority of people answered false, right? So definitely acute infection and window periods are defined very differently, right? There's two separate definitions to each one, right? So the definition of a window period in HIV testing is the length of time after infection that it takes for the virus to become detectable by an HIV test. And I want to put virus in quotes, and you'll see why in a minute. And this varies depending on the test. So there's different types of tests, right? So depending on the test, there's different window periods. And the window period is pretty much the length of time after infection that we can detect whether someone is positive or not, right? And I put quotes around virus, and you'll see why in a minute. And when we talk about acute infection, is the initial stages of infection, of HIV infection, when the virus is multiplying rapidly, right? And this is a key thing that I want to highlight, is rapidly, and the body has not yet developed antibodies to fight it. So the body's reaction to a virus or any outside bacteria or what have you it develops antibodies to fight it, right? So during acute infection, the body hasn't developed antibodies to fight that virus yet, right? So with that said, I have a follow-up question. Is there a test that can detect HIV during acute infection? So is there a test that can detect whether someone's positive or negative before the body's developed antibodies? So you have about 12 people answer so far. So is there a test that exists that can detect whether someone's positive or negative before they develop antibodies? Right, so this is perfect. The majority of people answered correctly, right? So there's definitely a test that detects whether someone is HIV positive or negative. But the thing is, it doesn't detect or look for antibodies or antigens. What it looks for is the actual virus itself. And you'll see that it looks for the RNA plasma, which is what you'll see here in the blue line. So there's ultimately the way in which tests are categorized when it comes to HIV testing is generally done by generation. So you'll hear that a test is a first generation, a third generation, a second generation, what have you, right? So HIV test, the first and second generation test detects antibodies. So again, the things that the body develops to fight the virus, which appear later in the course of HIV infection. First generation antibody tests, including the Western blot, have window periods of approximately 6 weeks, right? So the window periods of a second generation antibody test is approximately 4 to 6 weeks, right? Third generation antibody tests have window periods of approximately 3 to 4 weeks. Fourth generation tests, so those are the ones that are more recent, that can test more sooner, can test infection sooner. Test both antibodies and what are called antigens. The window period for this fourth generation test is approximately 2 to 3 weeks. The test that can detect whether someone is positive or negative during acute infection is what we call a NAT test, or a nucleic acid test, and it detects the virus itself. So it's not testing for the antigens or the antibodies. What this test does, it tries to look for the virus itself. So that test can detect whether someone is positive or negative during acute infection, right? So again, all these different types of tests exist out in the world in the work that we do, which really makes it difficult to start communicating to a client, hey, this is what this test result means, right? And this is where it starts getting tricky. So the question I have for you is, what testing technology does your organization use? Is it first generation, second generation, third, fourth? Don't know or don't offer testing. What's your response? First generation, second generation, third generation, fourth generation, and don't know or don't offer testing. What, 11 people, 10 people answered, 12 people answered so far, 13, 14 people. So do you offer the first generation test, second generation, third, fourth, don't know, or don't offer testing? Right? So this is good to know on my end right now. So we have about 90 people answer. About four people on the call with us today don't offer testing, which is good because it kind of lets me know how to start framing this conversation differently. But a majority of agencies or partners on the call right now use second generation. And again, the second generation test it has a window period of 4 to 6 weeks, followed by first and third. So again, what I'm going to do right now is, why is it important that we accurately communicate to clients what an HIV negative test result means? Why is this important? And I'm going to unmute the lines because I want to make sure I hear people speak about this topic. Why is it important? Why am I spending so much time talking about window periods right now? So I'm going to unmute the lines.
The conference has been unmuted.
Why is it important that we accurately communicate to clients what an HIV negative result means? Feel free to jump in. The lines are currently unmuted.
Well, I would say that a negative result means that if a person has been in a high risk, is that until that moment, the test result indicate that it's negative until that moment, but the test result could change in the future.
Mm-hmm. Definitely. And again, the fact that it can change in the future is a big component, but it's still very telling, the fact that we're giving someone a negative result. We need to be mindful of describing to them what that means based on the test that we're using, right?
They could be in the window period where their antibodies aren't detectable yet.
Exactly. So based on the test that we gave them, maybe we're using a test that detects the virus, or the test that detects the antibodies 3 to 4 weeks after infection. But hey, if that person engaged in risky behavior or came in contact with the virus 3 weeks ago or 4 weeks and after, that test isn't going to recognize it, but we're giving them a negative result, right? So it's important for us to understand what technology we're using, what that window period means, and how we can effectively communicate that information to our clients so that they know what that negative result means, especially in cases where this test isn't accounting for acute infection. And remember what I said earlier, that during acute infection, the virus is spreading rapidly, and that someone is contagious at a higher rate than they are when they're not in acute infection, right? So usually when someone has a very high viral load during acute infection, because the virus is spreading rapidly and there's no antibodies to spread it, meaning that the person is more infectious, right? So it's critical that when we're talking about window periods, that we speak to our clients effectively based on the technology that we're using, so that they understand what that negative result means, right? Does everyone see the importance of that? And Jesse said right now in the chat, perfect opportunity to talk about risk factors. Definitely, right? So during this time when we're speaking about window periods and what a negative result means to their client, it should be part of a regular conversation, risk reduction and harm reduction, right? And Leah said the client needs to know they are still at risk for contracting HIV, right? So again, this test that I'm giving you that says negative accounts for any risky behavior that you engaged in during that window period, right? Or beyond that window period, right? So again, very key that we communicate this effectively, right? And I'm going to put the lines back on mute.
The conference has been muted.
Most tests really could be done in two methods, right? We have laboratory-based versus point-of-care rapid testing. And the testing got cut up there. I'm sorry, it's supposed to say testing. But the main difference is that in laboratory HIV testing involves obtaining specimen from a patient and sending it to a laboratory for processing. Most laboratories use several tests in a sequence, so they'll use different testing mechanisms to make sure that the result they're giving is accurate. So if the test first result is reactive one or more tests may be done conducted after that to make sure that that test is confirmed. If a test is performed in-house, such as at a hospital laboratories, that result can be given to the client within several hours. But if testing is performed elsewhere outside of a separate laboratory, it takes a little longer because, again, you have to send the specimens to that laboratory elsewhere and then have them send you the results back, right? So laboratory tests are beneficial in the fact that they're more accurate. They tend to be more accurate because the window period sometimes tends to be smaller, and they're more precise because they do multiple tests when a test comes back reactive. But there's also other options, right? And these are the cases in which most community-based organizations work, where they have point-of-care rapid testing. And these are situations in which a client can get tested where they're receiving services elsewhere. So these tests have been categorized as WAVE tests or under CLIA waivers or clinical laboratory improvement amendments. The point-of-care rapid HIV test is just that. It's a test conducted where the client receives services and results are typically available in the same day. A reactive test or a positive test result requires supplemental laboratory testing to confirm the diagnosis of HIV. So if someone comes out positive in a point-of-care rapid test, ultimately it's still recommended and definitely will be happening within your protocol that that test is confirmed through laboratory test results, right? And there's general guidelines as far as how this looks nationally from CDC guidelines. And the way that's implemented locally within your state and agency should be pretty much well scripted. Otherwise, you wouldn't have a clear waiver, right? And there's different ways in which test technology looks based on your setting and those window periods. So you'll see that's kind of represented on a table here on the screen. So again, the difference between a point of care and generally a CBO or a clinic that can happen also. But again, some of these lines are murky. It could function in a way where a CBO functions in a clinical setting or an FTHC. So, and sometimes those cases might be where there might be a laboratory in-house. So again, it's important for us to understand the difference between these two and how they operate. So now I'm going to go into the topic speaking specifically around strategies and engaging Latinos for testing. And I want to make sure that when I do this, what I'm going to let you guys know that I'm doing is I'm presenting a framework in which you can look at engaging Latinos and the reason why Latinos aren't testing for HIV or being diagnosed for HIV at late stages of HIV infection, right? Generally in the United States, there's two methods that are used. These are two main methods that are used as far as testing goes in the United States, and that's the routine HIV testing method and the targeted HIV testing method. And the main difference between these two is that the routine HIV testing method is generally done where CDC recommends that anytime someone goes into a doctor, that they get tested for HIV no matter what their risk factors are, right? So they're not necessarily targeting someone based on the risk factors or what they're engaging in. They're saying if you're someone between the ages of 13 and 64 and you're going to the doctor or a clinical setting, it is recommended that you get tested for HIV, right? So in this setting, people are given the option to opt out of HIV testing. So it's part of the consent form. But it's recommended in routine testing that no matter what your risk factors are, that you're tested, right? So no matter who you are, as long as you're between the ages of 13 to 64, it's recommended that you get tested. And it's great because ultimately what it does is it normalizes testing. The problem here, the loophole here is that if someone isn't engaged in regular medical care, they're not going to get offered that HIV test, right? There's also other barriers that exist in routine HIV testing. If the doctor doesn't bring up the HIV test with the client or doesn't feel comfortable bringing up that topic with the client due to language barriers or general stigma associated with talking about HIV, that person will be given the test. And that's something we see very often, that even though it's recommended that doctors and primary care physicians offer HIV tests as part of the regular medical care, this isn't being offered, right? So there's several things in areas that we need to still continue to work on and make sure that this functions properly. And then there's also this thing called targeted HIV testing. And targeted HIV testing is different than routine HIV testing in that targeted HIV testing does just that. It targets specific populations of people that are considered high risk based on their behavior to get tested for HIV, right? So we're going out looking for people that fit particular demographic information, certain risk behavior characteristics, and we're saying, hey, we want to make sure that you get tested for HIV, you specifically based on your the population demographics that you fit, right? And one of the key things when we're talking about targeted testing is who exactly we're targeting, right? And in the realm of HIV, in the field of HIV, we often refer to these populations as priority populations. And again, like we saw a minute ago, priority populations really differ based on who our funders are, based on where we're located. But the way in which we define priority populations is ultimately up to us, and looking at data and making sure that we do formative assessments to make sure that we're identifying people accurately as a priority population and are really part of this risk population, right? So what I want to do right now is I have another poll question. I'm full of poll questions right now. And this is one where you have to type in an answer, right? So you want to type in an answer. And the question is, what puts Latinos, Hispanic at higher risk of contracting HIV? So type in your answers. So what puts Latinos at higher risk of HIV, contracting HIV? Someone said machismo. So type in what do you think puts Hispanics or Latinos at higher risk of contracting HIV? The lack of knowledge and resources, right? Very good point. So if someone doesn't know they're at risk for HIV, they won't consider it a priority, right? Or maybe they just don't know how HIV is transmitted, right? So maybe they're engaging in risky behavior that can put them at risk for HIV, but they just don't know it. So someone said falta de información, falta de acceso. So again, lack of resources, lack of information. Reluctance to go to medical providers. So again, that mistrust between the medical care system and the recipient, the client, especially in the context of undocumented individuals where they have a general mistrust of healthcare systems in general or government agencies in general. They don't want to be deported. They don't want to be reported. All these contexts are very critical of the way Latinos access healthcare. Lack of access to care, culture. So again, there's definitely cultural barriers and belief systems that also trigger higher rates of HIV infection. And especially if we work in organizations where the services aren't culturally competent and someone doesn't feel comfortable accessing those services, they're not going to come get tested, definitely. Fear to know that they got it, definitely, that's a big one, right? If someone receives an HIV positive status, that means they have to deal with that status, right? So that's a major issue that we encounter with Latinos and populations in general, is that the fact once someone receives an HIV positive diagnosis, it means that it sometimes becomes real to them, so some people just rather not know, right? Appropriate education around risk factors, so definitely making sure that we communicate effectively to Latinos in a way that they can understand around what puts them at risk for HIV. Religious stigma against the LGBT community, right? And again, this is something that we can try to address in a partnership approach. One of the programs that we're very proud of here at the Commission is the Latino Religious Leadership Project. And this is one in which we engage Latino leaders in the conversation around HIV/AIDS transmission and addressing that in a healthy way. So definitely making sure that we try to address that issue of stigma with faith-based leaders is key. Trust, lack of materials and information in Spanish. So again, depending on where we're working in a lot of our locations, especially in the South, we're seeing that there's a huge emerging population of Latinos from multiple areas, either from the Northeast, from other countries, where the service providers there are having a very difficult time catching up to the times. So it's critical that in these populations, in these areas, where we're seeing a very high, quickly emerging population, that we work with our partners there locally to make sure that we provide them with resources to be able to effectively provide services to Latinos in those areas, and that these partners locally in those areas where there's high emerging populations, Latino populations, that we work with them to help them realize the importance of effectively engaging Latinos when it comes to HIV testing. So definitely, big thing. And of course, we can never forget stigma. Stigma is a big thing across the board, right? Stigma around HIV, stigma around plenty of other things, right? Stigma is a key part as to why someone might not want to get tested or what puts them at risk for HIV. So the way in which we generally define populations as a priority population, and you'll see this in sometimes many grants, or when you ask somebody, what's your priority population, or what's your target population, they'll include things like this, right? And the most basic of things is demographic information, so age, gender, things like ethnicity, sexual orientation, But there's also other ways in which you can define populations, things like social structure, education, occupation, ethnicities, you know, things like, you know, immigration status, coping mechanisms, health environment, and health beliefs, right? So attitude, values, and knowledge, right? So maybe you can define that our population as Latino immigrants who don't believe they're at risk for HIV infection, right? And there's also other things that influence risk and characteristics in which we can define characteristics, and we call those under the category of enabling resources, right? So peer norms, and these are things more around structural situations that pertain to agencies and our own organizations, things like counseling tests, making sure that we provide accurate testing technologies or use tests that really reflect the need of the populations, making sure that we have counseling and testers that are able to communicate with the populations that we're working with effectively, right? So again, these factors range, and you guys did an amazing job of identifying a lot of those risk factors right now. But revisiting one of our slides earlier, factors such as lack of health insurance, language barriers, lack of familiarity with U.S. healthcare systems, and stigma often limit access of Latinos to healthcare, which results in limited opportunities for HIV/AIDS screening. So again, plenty of things that we need to look at. And when we're talking about engaging Latinos for HIV testing, we can't separate these things, right? We can't not talk about language. We can't not talk about healthcare access. We can't not talk about stigma, because all those things are going to impact whether someone gets tested for HIV or not. And that varies a lot depending on where you're located. So when you're engaging populations to get tested, it's important for us to look at the environment, those social determinants, to figure out what's preventing the population that I'm working with in getting tested. And the way in which we put that in a formula is by this principle that we use at the Commission very often, and that's the behavior, and it's more easy than it looks. But the way we describe it is it's Lewin's equation. It's the behavior, which is this B, is a function of the person, the characteristics, and the environment. So in layman's terms, what that means is the behavior, in this case it's not testing, is a function, is influenced by the person's characteristics, whether they're a woman, whether they're a man, whether they're MSM, whether they're undocumented, what have you, and also the social determinants, right? So things that are happening in their environment. So maybe there's not testing offered to them in a culturally competent way, and that's going to influence them not to get tested. Maybe there's a lot of homelessness. Maybe there's a lot of stigma. There's a lack of social support. All these things combined influence why someone decides to or not to get tested. So when we're talking about testing Latinos and we define those populations by certain characteristics, it's important to us to also address and identify, well, what's presented, what in the environment that we need to address to make sure that person feels more comfortable getting tested, right? Is it a lack of knowledge? If it's a lack of knowledge, then hey, your recruitment strategy is going to be focused on providing knowledge around what puts people at risk of HIV to try to influence that population to get tested. If it's around lack of transportation, guess what? Your strategy is going to be focused on providing transportation to help that population get to locations where they can get tested. So again, this is a key way to look at testing, which will help you determine how you could effectively engage and strategize around making sure that Latinos get tested in your specific location and environment and conditions that they're living in. Another way that we're looking at testing, in a lot of settings that we're working in, we're tasked to find a certain number of positives, which has definitely made our work a little difficult, but it's still very important that we do it. What we had happen before was that before, testing and our funder wasn't monitoring the number of positives as much as they are now, but that's key, right? It's no longer just about testing 200, 300, 500 people. It's about testing the people that are high risk. And the way in which a lot of organizations are going about doing this is rather than just offering anyone and everyone a test, they do the screening and risk assessment before they even offer the test, right? So usually a lot of organizations are doing a risk assessment after they wait for the test result to come out during those 20 minutes. It's a oral rapid test. What a lot of organizations now are doing is they're doing a screening, meaning that they'll screen the person to see where they're engaging in high-risk behavior, or they fit the demographic or priority population that they're targeting. And if they don't, if the person presents no risk factors, there's no reason why that person should be tested. But it doesn't mean that they can't be referred to other services. So it's not a loss, as in the person's not getting anything out of not getting tested. They're still gaining knowledge. You're still addressing that knowledge piece. You're still addressing some misconceptions. You're still sitting in front of them to speak about any other issues that might influence or engage in any risk reduction. So there's definitely methods in which organizations are using to make sure that they're testing the right populations, right? And this is specifically around targeted testing, right? We usually do screening when we're doing targeted testing. One of the services we have to offer that I want to make sure I promote here is that the Commission has, if you need further support, there's free customized support that we can provide you through our Capacity Building Assistance Division here at the Commission. And what we do through that is if you have a specific particular effort that you want to work on, let's say you want to develop a social media strategy to help you recruit for testing, or if you want to do social network strategy, or if you want to do a training on cultural competency to improve your testing efforts, we can provide you with that type of technical support and training. And you can solicit this type of information or support, and again, this is free, by contacting us with information located there at the bottom. Our program director here, Bolivar, is very keen on making sure that we address the needs in a very customized, holistic approach, and any way in which we can support you through our capacity building assistance efforts, we would love to do that. So we encourage you to solicit that type of support. And with that said, before I close, you have about 4 minutes left. That's all I have to talk about right now. But I want to unmute the lines and make sure that people are able to pose any questions.
The conference has been unmuted.
So does anyone have any general questions or comments or feedback?
I have a comment.
Yep.
My name is Ivan. I'm from Virginia, a very rural town. And with the screening before offering the test, I feel like, for example, if a group of friends come and get tested and you're screening all of them before you offer the test, wouldn't that further stigmatize getting tested because you're separating them into, okay, you're higher risk and so you need to be tested?
Assessment, unless you're doing a very different intervention, like couples counseling and testing, when you do a risk assessment, that risk assessment should usually be doing in a private setting. So it could ultimately, the person can come in and out of that testing location without the people outside knowing whether that person got tested or not. You know what I mean?
Yeah.
And it's not like, again, if that person isn't offered the test because they're not exemplifying any type of risk factors, there's still a learning aha moment there, because that person then is leaving that session with you, that counseling session, with a better understanding of what puts them at risk. Or during that session, they'll openly tell you, okay, well, let me actually be honest with you as far as what my risk has really been. Okay?
Okay. All right. Usually the way we do it is we do the risk assessment before we get tested. Of course, they fill out the form and then we go back and discuss the risk in a private setting. That's why. But when we're out in the community, we also test them. We usually have them fill out the form outside of our testing van.
Gotcha. So you have them fill it out themselves, and then you collect it, and then you tell them whether they get the test or not?
No, we collect it, and then we perform the test. And then we discuss the risk factors while we're doing the test.
But you're still doing that in a private setting, right?
Yeah.
Fill out a risk factor, their risk factor, and then
so that's why, and sometimes, especially with colleges or we're out in the community, and like, I don't know, sometimes we set up in neighborhoods.
Mm-hmm.
We have friends coming in, and they all fill out their risk factors, and then we take them one by one into our testing.
Yeah, definitely. And again, those all should be each organization's particular protocols around how they offer tests, whether they're in a mobile unit, whether they're at a testing party, whether they're at a specific location, off-site, on-site. Those are usually amended by the organization's individual processes. So we definitely invite you to assess whether our screening tools work for you or not, and if they do, that you're using them in an effective way that really still keep to the person's confidentiality.
Okay, yeah, I just had that question, but if you're taking them back anyway.
Yeah, definitely.
The risk factors. Okay, then. Okay, all right then.
Right. Else? Any other questions or comments? I want to thank everyone that's felt comfortable enough to open up and ask questions. I think that's key, and it's definitely a learning moment for all of us on the call to make sure that we address these things. I'm sure oftentimes a lot of people had the questions that we're asking, but might not feel comfortable, putting themselves out there. So I commend you for doing so. Questions about anything we talked about so far, whether it's about NLAD, whether it's about testing technologies, epi data, anything whatsoever. Well, thank you all again for joining us. Hopefully you guys found those poll questions encouraging as part of the process. And again, my contact information is on the screen there. And don't hesitate to contact me about anything about NLAD or any other topics discussed, all right? Thanks again for joining us, and I want to make sure that I stay true to time. It's a minute after 4, so take care, everyone.
Take care.